So greetings, everyone. Tonight we have another very special subspecialty VMR with a focus on clinical reasoning. For that, we have two incredible guests, Tony and Eleni. Tony is an internist, a hospitalist at the VA Boston, and faculty at the Center for Bioethics at Harvard Medical School, and a co-host of the Curious Clinicians podcast. Thank you so much for joining us, Tony.
Thank you for having me.
And I would love if Tony could tell us a little bit about why he created the Curious Clinicians podcast and what it's intended for, and what do you do for fun outside of medicine?
So full disclosure, Avi Cooper was who's one of the co-hosts along with Hannah Abrams, was the person who really wanted to start the podcast. And when he had the idea of sharing curiosity in medicine with others, said he was going to do that, I wasn't going to allow him to do it without me joining him. So he should take the credit, but the real goal that the three of us have is to just, again, share our enthusiasm for medicine and the sort of joy that you can get by asking curious questions and seeking out the answers. And we've had a blast doing it. Fortunately, I think a few people have enjoyed listening.
And what do you do for fun outside of medicine?
I have a 4 and a 7-year-old, so I don't do anything fun outside of medicine other than hang out with them. That is a lot of fun, but I am a doctor and a husband and a father, and all three of those are full-time jobs. I have no hobbies.
Amazing. Thank you. Yeah, it sounds very time consuming for sure. And we also have Eleni. She's a pediatric internal medicine resident at the Boston University. Thank you so much for joining us, Eleni.
Hi, everyone. Thank you so much for having me. Thank you, Tony, for the invitation. It's a pleasure.
Thank you for coming. I would love it if you could tell us a little bit about a project that you've been currently working on and what do you do for fun outside of medicine as well.
Mm-hmm. Of course. So I'm very interested in rheumatologic dermatology. So currently I'm working on a quality improvement / research project trying to investigate the adherence to medications in patients who have cutaneous lupus and trying to find ways to improve the adherence to the oral medication, which has been very fun. Outside of medicine, I really enjoy dancing salsa and kizomba and exercising.
Sounds cool. Sounds so much fun. And we also have with us Madalena. She'll be presenting the case. Could you introduce yourself, Madalena, and tell us a little bit about what you do for fun outside of medicine as well, please?
Yeah, sure. Well, hello, everyone. My name is Madalena Conti. I'm a third-year medical student in New York. And for fun, I like to spend time with my siblings. I also used to be a figure skater. So sometimes, watch figure skating more so than I skate these days and just do anything outside.
I also saw on the spreadsheet that Seth is describing. I don't know if you can unmute yourself, talk a little bit about yourself as well. If not, that's totally fine.
Yeah, I'm going to try to describe. I think I have everything set up, so we should be good.
So Seth,
sorry, I didn't hear you.
Could you tell us a little bit about yourself as well?
Oh yeah, of course. So my name is Seth Boyd, 4th-year medical student at LECOM from their Bradenton campus down in Florida. I am currently in Orlando right now. I went to UCF here, so just trying to finish my 4th year strong, and then I will be doing an IM residency in Orange Park, which is next to Jacksonville.
Congratulations, and thank you for starting. Maybe you can share the screen and then we can start with Madalena.
Yeah, one moment. Let me figure this out. One second. All right, you guys able to see it?
Sure can.
Perfect.
Yeah, thank you so much. The last but not the least, maybe Shema could introduce herself. She'll be doing the teaching points.
Sure. Hi, everyone. My name is Shema. I'm a 5th-year medical student from Berlin. And besides medicine, I enjoy watching true crime documentaries.
Oh my God, sounds so much fun. So curious. Thank you for sharing that. Please, Madalena, can you start the case?
Yes, okay, so Tony and Eleni, I will give you the case in about 4 aliquots and pause after each aliquot for you to share your thoughts. And to, if I'm ever talking too fast, just let me know, and especially Seth for the scribe, let me know if you want me to repeat anything. So without further ado, we'll jump right in. So the chief concern in this case is abdominal pain and distension. And I'll give you a little bit of the HPI as well. So this is a case of a 52-year-old man who's presenting with abdominal pain and distension for 1 month duration. When asked about the pain, he says his pain is more severe in the lower abdomen than in the upper abdomen, and he also feels more distended than usual. He said he has taken Tylenol for the past few days for the pain, but it only gave him very mild relief. When asked about any changes to his bowel movement pattern, he states that 3 or 4 months ago, he had constipation, but starting 1 month ago, he began having pretty consistent diarrhea. So he describes the diarrhea as watery, non-bloody, and usually 4 to 5 times a day, usually 1 hour after eating. He denies any blood in his stool or black stool. So he presented with these symptoms to his primary medical doctor for a physical exam on the day of presentation, and then was sent directly to the ED for further workup. So I will pause there and would love to hear your thoughts about what's coming to your mind now.
Eleni, you want to take the first crack?
Happy to start. So I see here that we have a middle-aged male who comes in with subacute to chronic abdominal pain, distension, and changes in his bowel habits, constipation, switching to diarrhea related to food. So I'm trying to think, am I dealing with an absorption problem? Am I dealing with an infectious problem? Am I dealing with a malignant process or inflammatory process? And I would love to hear, are there any specific foods that are bringing this distension, or it's immediately after eating anything?
That's great. So I'll add a few things. When you first hear abdominal pain in a middle-aged person, the differential is obviously enormous. And often we will tackle abdominal pain in a sort of a geographic manner and say, okay, this is lower abdominal, this is right upper quadrant, this is left upper quadrant, this is diffuse. And then attempt to localize an organ that sits in that region, knowing that organs can traverse the midline, they can travel in some ways. Particularly as they enlarge. What's interesting about this case is that the context of having constipation and diarrhea really suggests that we're localizing to the lumen, or to luminal organs, right? Could this patient have pancreatic insufficiency from a really bad bout of pancreatitis and thereby leading to diarrhea? Sure. Could they have biliary disease and have bile salt related diarrhea? Sure. But most commonly when you have diarrhea, you're talking about small bowel or large bowel disease. And so what that does is it takes us from what is typically a geographic localization to abdominal pain. And it really makes us wonder, are we dealing with one of the 2 main lumens, right? The small or the large bowel. When you have constipation first, followed by diarrhea, that sort of suggests you're dealing with more of a large bowel problem if you're dealing with one or the other. And it's so early that you certainly can't take solid organs off the table. And then once you get to a colonic potential problem, all of these important etiologies that Eleni was alluding to, inflammatory causes, malignant causes, infectious causes, all of which can lead to forms of colitis. Those begin to sort of increase in probability. And so what you're going to be doing is ensuring that when you take your review of systems, you remember that there will be specters of those inflammatory diseases in the usual ways: fevers, chills, weight loss, fatigue. But that some of these diseases that can coalesce around the colon also have odd manifestations in atypical places. So inflammatory bowel disease, for example, have joint, back involvement, skin involvement, eye involvement. And so, for the students and the interns who are listening, you have to remember that your review of symptoms often has to be broadened dramatically beyond what you would otherwise anticipate. So we don't have obviously enough information to really say for certain if we're dealing with a colonic thing, but the fact that the pain is associated with what appears to be a luminal issue, constipation and diarrhea, and that luminal issue started with constipation really suggests that maybe we're dealing with something in the colon. The other thing that I'll mention is distension is, I think I learned from the clinical problem solvers that when you hear someone talk about a distended abdomen, you have to think about the sorts of things that can make an abdomen large. And typically that's organomegaly, that's air, that's fluid in the form of ascites. And in this case, I guess air is a possibility. Though I will tell you, when I heard the first line, I assumed we were going to be dealing with someone who has ascites. And so the reason I bring this up is that, again, when we're doing our history and importantly, our physical exam, we're probably gonna have to be a little bit more attentive than we otherwise might be to looking for evidence of things like ascites. Unless on the remainder of the review of systems, it's quite clear that we're dealing with something other than that.
And that was a fantastic discussion. What really stood out to me is whenever I've come across abdominal pain, I found it so difficult to localize because, as you said, all the organs are so close together. So it was very impressive to see you kind of prioritize the location of the disease based off of some of those symptoms. So without further ado, we'll move on to the next aliquot. So I'll give you a little bit more of the HPI. So in addition to this abdominal pain and change in bowel movement pattern, he says that his wife has told him that his eyes have been yellow for the past week. He also describes a decreased appetite because of this abdominal pain and diarrhea. And when asked about his weight, he reports a 30-pound unintentional weight loss in the past month. He also states that he has just felt more tired and decreased energy levels overall. In terms of some health maintenance items, he has never had a colonoscopy or an endoscopy. He says that he did have a colon cancer screening, which was a fecal occult blood test back in 2019, so 3 years ago, which was negative. So in review of systems, kind of as a summary of what we just talked about, he's reporting fatigue, this yellowing of his eyes and skin that he's noticed, this abdominal distension and pain, this diarrhea with the previous history of constipation. But the review of systems is negative for cough, shortness of breath, chest pain, any vomiting, no hematuria, no itching or other skin changes. So I'll now give you some more of his past medical history. So he says he's been diagnosed with hypertension, type 2 diabetes, and GERD. He says these are all well managed with medications, and he does not report any difficulty keeping up with those medications. No surgical history. For family history, he says that his sister has cirrhosis, but he's not sure any details beyond that. He says that his brother has hypertension and died of lung cancer a few years back. And he says that his mother has type 2 diabetes. In terms of social history, he describes that he moved from Ecuador around 30 years ago, but has not been there in many years. He currently works at a flower shop in New York City. He's in a monogamous relationship with his wife, whom he lives with. He has no children. And he does not report any recent travel, no animal exposure or sick contacts. And he does not report any alcohol use, tobacco use, or other drug use. And then in terms of medications, he takes metformin, he takes Levemir, he takes Novolog, amlodipine, losartan, hydrochlorothiazide, omeprazole, a statin, and gabapentin. And I will pause there to hear your thoughts.
So Eleni, I'll talk first, but I want to give you an option for which you want to address it. When you go, do you want to address the review of symptoms, or do you want to address sort of the past medical and family history?
Happy to do the review of systems.
Okay. So Maddie, a question about the diabetes diagnosis. Is that at all recent?
No, that's not recent. He said that he has been living with that diagnosis for the past 10 to 15 years, he said.
Okay. And just the reason I asked that question is, we hear this patient is jaundiced. This is not, they don't have elevated like beta carotene, right? So this patient is jaundiced. At least he's telling us that. And I think we immediately coalesce to the common bile duct or intrahepatic causes of jaundice, but just have to remember, and again, a patient abdominal pain and diarrhea and 30 pounds weight loss, I just want to make sure there's nothing going on in the pancreas. So, acute diabetes in the setting of jaundice and abdominal pain, that is pancreatic adenocarcinoma. This gentleman has had his diabetes for a lot longer than that. So doesn't mean he doesn't have pancreatic adenocarcinoma, but it makes it a little bit less likely. The sister with cirrhosis is, of course, interesting. And it would be interesting, Maddie, if you're comfortable disclosing, if you know the context of that. This case is unfolding in the United States. Is the sister also from Ecuador? And do we even know anything about her diagnosis for cirrhosis? If you're comfortable disclosing that.
Yeah, so I actually don't have much more information. He said that his sister is actually still in Ecuador, and he really doesn't know much more information besides that she's told him that she has cirrhosis. Okay.
And the reason I ask that question is that sometimes people will told they have cirrhosis when they actually just have non-cirrhotic portal hypertension, because it looks for all the world like cirrhosis. And in countries outside the United States, the most common cause of non-cirrhotic portal hypertension will be something like schistosomiasis. So just already beginning to think about, when we do the physical exam, if there is evidence of ascites, and that's why there's distension, not just assuming that this is from cirrhosis. But when you have a family history of cirrhosis, you have to begin thinking about heritable causes like hemochromatosis. And so particularly if you layer on top of that, I would say, not non-strong family history of diabetes. It could be that this is type 2 diabetes, which has a strong genetic predisposition. But if we hear, for example, that this patient has bad arthritis in the hands, particularly the second and third digits, or the knees, and it's just not something that they felt like they needed to mention because everyone's got a little bit of arthritis, well, then the specter of something like hemochromatosis increases a bit, particularly given this family history. I'm going to defer any further comment about Ecuador until we have a better sense of what we're actually dealing with, because the whether or not that has any relevance, I think, is going to be determined a little bit by what we decide could potentially be going on. And I also am going to defer any comment on a flower shop because, I just can't imagine sporotrichosis, leading to this. And Maddie would not do that to us because that would be unfair. So Eleni, maybe you want to comment a little bit on the review of symptoms?
Absolutely. I'm going to start by talking about the icterus. You alluded to intrahepatic, extrahepatic processes and possible obstructive pathophysiology there. He's been experiencing significant weight loss, which is also pointing towards either like a more subacute inflammatory infectious process or a malignant process or infiltrative process as well, together with the fatigue, which is not very non-specific.
I'll make one comment. So Maddie, you mentioned the lack of itching or pruritus, is that right?
Yes.
So does that prove that this patient doesn't have a cholestatic cause of jaundice? I would say it doesn't. But the reason I suspect you were asking that question was to see, am I increasing the probability that they have a cholestatic cause of jaundice? And the fact that they don't have pruritus or itching, I would say makes cholestasis a little bit less likely. But I will admit that right now I am confused because what I cannot yet put together is this constipation followed by diarrhea, right? We're going to need to get a physical exam and some labs, and I suspect the physical exam is going to be next. But we've got these two things that some of us probably here tonight can see how those Venn diagrams overlap, right? What I was initially thinking was going to be a luminal issue, and then suddenly we appear to be coalescing around the hepatobiliary tree. And to be full transparency, I'm assuming this is a direct hyperbilirubinemia because everything seems to be coalescing around the GI tract. Could this patient be hemolyzing? Absolutely, but everything seems to be in the belly. So I need to think a little bit about how we can overlap those Venn diagrams. And Eleni, I'm not sure, can you do that quite yet for us?
Not yet. I think that the exam and the labs would really help towards that direction.
Yeah. Now, if this patient had a long history of inflammatory bowel disease, and now we're dealing with primary biliary cholangitis, okay, fine. But this patient doesn't have a long history of inflammatory bowel disease, so I don't think it can be that.
Wow, just such a beautiful discussion. I think what stood out to me is how you're teasing through what is signal, what is noise, what symptoms are contributing to the dominant problem versus not. So it's wonderful to listen to you both. So moving on to the next aliquot, I'll give you the exam and some initial labs. So for some vitals first, his Tmax was 37.1 Celsius, heart rate 99, blood pressure 126/66, respiratory rate 18, and he's saturating 96% on room air. So in general, he is in no acute distress. He's lying comfortably in the bed, but he does appear mildly fatigued. In terms of the HEE and T, his extraocular muscles are intact. He does have notable scleral icterus, moist mucous membranes, and his neck is supple without JVD. Cardiovascular exam, he is tachycardic with a regular rate and rhythm. Pulmonary exam, there's overall unlabored respirations. There was some mild inspiratory wheezes at the lung bases. Abdominal exam was distended and diffusely tender to palpation, more so in the right lower abdomen. There was hepatomegaly noted and also a fluid wave. And in terms of the extremities, 2+ peripheral pulses bilaterally, no edema was noted. There was full strength in his extremities, and the skin was jaundiced, but with no rashes. And the neuro exam, he was alert and oriented ×3, no focal deficits, no asterixis. And I will move on to give
Maddie,
you.
can
I
ask a quick question about the physical exam?
Yes.
The respiratory rate, did we have that by any chance?
The respiratory rate, 18.
Yeah. Okay, great. Thank you.
Did you want to comment on this, or do you want me to?
That's the clincher. I think we know what the answer is now, that the respiratory rate is 18. I had to ask.
Yeah.
Yeah. Why don't I just briefly comment on the exam,
please.
and then maybe we'll do some labs and we'll let Eleni take first crack at that, because I think all of us here in the room are excited to hear the labs. This patient is jaundiced. They have ascites, unless Maddie is trying to tell us that the physical exam is horrible for the assessment of ascites. And so I think here in the United States, our assumption is this patient has cirrhosis, far and away the most common cause of ascites. But I did not hear anything suggesting the other key feature of cirrhosis, right? I'm hearing things that would suggest portal hypertension, thing, really the ascites. But I'm not hearing much suggesting the elevated estrogen levels that would come along with cirrhosis. So I begin to wonder again about non-cirrhotic portal hypertension. And of course, we must consider causes of ascites that are not related to portal hypertension. Those include all the inflammatory causes that we would typically think about: infectious malignancy, and even, for example, nephrotic syndrome. So the exam is interesting, and it, again, this is where you really have to do a good job of looking for spiders, looking for pulmonary erythema, looking for gynecomastia, because you can miss those things. And not hearing any of those, I'm very intrigued. So maybe Maddie, do you think time for some laboratories?
Yes, I will give you some basic labs. So we'll first start with chemistry. So the sodium, actually see the hematology is first there. So we can start with hematology. So the hemoglobin was 10.7, hematocrit 32.9, white blood cell count 8.9, and platelets were 343. And moving on to the chemistry, sodium 136, potassium 3.8, chloride 105, bicarb 16, BUN 26, creatinine 0.95, glucose is 100, calcium 9.4, albumin 3.7, and I'll also give you some liver enzymes. So the T-bili was 6.9, the direct bili was 5.9, AST 123, ALT 81, ALK-Phos 658, and the PT was 16, INR 1.35. So I will pause there.
And I will start with the CBC, commenting on the anemia. We don't know what type of anemia this is, but we can definitely see anemia with any inflammatory process. We're suspecting here some type of cirrhosis, so anemia can be very frequently seen. And then kind of reassuringly, platelets are within normal limits, and no leukocytosis is also reassuring, but again, non-specific. Going to the chemistry, notably slightly decreased bicarb and normal kidney function. And then he definitely has very elevated total bili. I would have to calculate the R factor, but I see kind of a cholestatic pattern with the more pronounced ALK-Phos T-bili elevation compared to the mildly elevated AST, ALT, and INR borderline elevated.
So if we were to ask the group, does this patient have evidence of liver synthetic dysfunction? I wonder what the chat would say. Because if you had said to me, okay, we don't have Maddie telling us much on physical exams suggesting cirrhosis. Tony, you can get one lab. Oh gosh, I'm not sure what it would have been, but the albumin and the INR both being pretty darn normal, man, makes cirrhosis even less likely. What's confusing to me a little bit is the normal platelet count, because well, I don't know if this gentleman gets a paracentesis. I sure hope he does. But if he gets a paracentesis, we'll certainly have to see what the SAG is. But typically with portal hypertension, because of the hypersplenism that results, you have a low platelet count. So the platelet count being so hardy, there's a couple possibilities, right? One possibility is he's got a JAK2 mutation. He's got Budd-Chiari because you get thromboses of the hepatic vein. And so this is a relative thrombocytopenia for someone who's got an elevated platelet count at baseline, but I don't think that that's what we're dealing with here. I think what we're dealing with here is a patient who's got ascites, and I don't think this is related to cirrhosis. And so what we need to do is try to figure out what is going on. And typically what you do here is do a paracentesis, look at the SAG, and sort of go from there. Now, the other thing that's confusing me is this alkaline phosphatase. If you had said to me, Tony, predict the bilirubin, I might have said somewhere between 4 and 8. If you had said to me, Tony, predict the alkaline phosphatase, I probably would have said somewhere on the order of 2 to 250. This is higher than I would typically expect for a patient who's presenting with this kind of constellation of symptoms, particularly if we sort of confirm that they have ascites. And so that begins to bring up the specter of infiltrative diseases. Hemochromatosis is an infiltrative disease, but I'm kind of putting that aside because if that's going to lead to this set of symptoms, the patient's going to have cirrhosis, and I don't think this patient has cirrhosis. And I actually don't know that hemochromatosis as an infiltrative disease leads to an elevated alkaline phosphatase. I typically think about it as occurring with many of the other infiltrative diseases. And so I'm a bit confused about this. I wouldn't call it a disproportionately elevated alkaline phosphatase, but it's certainly higher than I was anticipating. Now, alk-phos can be generated, of course, not just in the hepatobiliary system, but it's made in the small bowel, it's made in the bone, it's made in the placenta. So you can get isoenzymes, but really the second most common location is going to be bone, and there's really no specter of bony disease here that has been brought up. So I'm not too worried about that. Final comment I'll make maybe before we hear what's next. Maddie, we're getting one additional aliquot after this, is that right?
So you will get one additional aliquot exactly before the final diagnosis is revealed.
Okay. So just on this comment of cirrhosis, that BUN, we'd be like, oh wow, BUN 26, that seems pretty darn normal. If this patient had cirrhosis, it's actually a pretty high BUN. And the thing to remember is we do biochemistry in medical school. I know there's a few medical students who are joining us this evening, and so this is an opportunity to say maybe there is a role for some of that biochemistry, because what process creates urea? Well, it's the aptly named urea cycle, and the urea cycle really has one main role, and that's to get rid of the toxic ammonia. Right? The body does not do well with ammonia. And humans, the way we address it is by turning it into urea, in, again, the aptly named urea cycle. And so patients who have cirrhosis are less apt to handle that ammonia and convert it to urea because their liver, where all this is happening, is malfunctioning. So we often think about having a low BUN or creatinine in patients who have cirrhosis because of decreased lean body mass, but one of the other reasons is that their ability to undergo the urea cycle is limited. So I wouldn't put too much stock in this, but it's kind of an interesting little correlation, knowing that Maddie, Raphael, and a few others here tonight are in medical school, and I think biochemistry gets a lot of heat. So sometimes you have to give it a little bit of love.
Yes, always good to know that the biochemistry is useful and relevant.
Well, I'm not sure that it's useful, but it's interesting.
Yeah. Okay, great. So I will move on to this next aliquot. I'm actually going, well, before I do, so you mentioned a paracentesis. I wanted to ask what other, how would you proceed with the workup at this point?
Maybe Eleni, you want to hit this one?
I would get an abdominal ultrasound with Dopplers for this patient. Definitely get the paracentesis to analyze the fluid. He did have some respiratory findings on exam, which might be or not related to the primary abdominal pathology. So we definitely image the lungs as well.
Yeah, I would do essentially that same set of things. I would confirm what we're suspicious for, and that's that there's fluid, peritoneal fluid, with ultrasound. I would probably ask a resident who's facile with doing bedside ultrasound to just do it for me because I have no idea what to do. And then I would say this person is probably going to get some additional imaging independent of whether or not we do a paracentesis. And there's so much that's confusing me about this case. This diarrhea remains confusing, and this alkaline phosphatase, that I would say cross-sectional imaging with a CAT scan is probably the imaging choice I would do after confirming they have ascites and doing a paracentesis.
Great. So so I will show you the imaging for this case. And I actually took a video of the CT scan that I'll share my screen to show you. But first, I'll tell you that a chest X-ray was obtained, which was clear, and an ultrasound was obtained, and I'll share with you kind of the read of the liver on that ultrasound. And that showed the read was innumerable isoechoic to hyperechoic lesions, the largest measuring 2 by 2.5 by 2 centimeters. And a CT scan was also obtained, and I'll actually share my screen to show you the CT scan before I give you the detailed read of some of the organs of interest. So let me go ahead and share my screen. Share screen. This will stop. Are you able to see the CT scan?
Yes.
You can.
Okay, so I'm going to play it. I apologize, I took a video on my phone, so it might be a little blurry.
So, as we look at this, we can see the hepatomegaly that Maddie was able to elicit on exam, right? That liver is sort of seems to be moving fairly low. And I assume you found it below the costal margin as opposed to across the midline. Is that right, Maddie?
Mm-hmm.
Okay. We're not seeing much ascites. At least I'm not seeing a lot of ascites. In fact, I'm not sure that I see a good pocket to get it. So if we don't get a paracentesis, I could understand. And then there is a line trying to measure something that appears to be in, I think, the pancreas. Is that the pancreas?
There was this line, then there was another line back here.
Okay, so I'm not sure if that's a lymph node. What is that one? There are other abdominal lymph nodes, it appears. So help us out, Maddie.
Yes, definitely.
What
So
are we seeing?
let me pull up my notes here. So what I'll do is I'll give you kind of a detailed read of some of the organs here, and then hear your comment, and then the next aliquot, I'll give you kind of the final impression.
Sounds good.
Okay, so this is all on the CT scan. So the liver, the comment was innumerable hypoattenuated lesions throughout the liver. For the bile ducts, the comment was no intra or extrahepatic biliary ductal dilatation. For the gallbladder, they commented mild pericholecystic fluid and gallbladder while thickening, no cholelithiasis. For the bowel, they said apple core lesion within the mid-transverse colon with a large extraluminal component representing extension into the gastrocolic ligament. The overall lesion, including the extraluminal component, measured 6.4 by 8 centimeters. So that was kind of the second line that we were seeing. For the peritoneum, the description was perihepatic ascites with areas of nodularity. And then the lymph nodes, which is what you were commenting on, was noted periportal adenopathy with the lymph node measuring 3 by 1.6 centimeters. There was also left para-aortic lymphadenopathy. and some additional prominent scattered mesenteric lymph nodes. So I will pause there to hear what your thoughts are from that read.
What do you think, Eleni?
Yeah, I think this is all very concerning for possibly a primary colonic malignancy, which is now metastatic to the abdominal lymph nodes and the liver. Kind of hearing this like apple or lesion and the lymphadenopathy and the numerous sites in the liver. So highly concerning for colonic malignancy.
Yeah, so let's, if we think back to what was confusing me, right? The first thing that confused me was, where is the colon, right? We initially were maybe honing in on the colon because of the diarrhea. And then what, at least I'll reflect on myself, what I became susceptible to was, oh my gosh, the wife says you're yellow. So the primary lesion is going to be in the hepatobiliary system, and was unable to tie in the fact that constipation and diarrhea were an initial concern. And so what we now have here is apparently a colonic lesion that could explain constipation and diarrhea. And certainly I think this gentleman had 30 pounds weight loss. If ultimately this is metastatic cancer, this would be unsurprising, an unsurprising finding to come along with that, along with the early satiety that he reported. So the fact that we now have a colonic lesion helps to explain that first thing that was confusing. The second thing that was confusing to me was an alkaline phosphatase over 600 is suggestive of an infiltrative process and not consistent with the usual pattern that you'll see with just an elevated bilirubin in the setting of liver disease, chronic liver disease, or even acute liver disease. So, patients, for example, who have acute alcoholic hepatitis, they don't get an alkaline phosphatase of 700. And so what you needed to show us, and what I think you did show us, was the infiltrative process. And here, I anticipate we're going to learn that the infiltrative process is metastases. Could he have some oddball colonic lesion that's an inflammatory lesion? I guess it's possible. I think this is in a really sort of screaming out to be a primary colonic lesion with metastatic foci to the liver, which would again explain this elevated alkaline phosphatase. So the two things that were confusing me seem to come together once we get to cross-sectional imaging. And so one of the nice things about this is it demonstrates well that your question to us, Maddie, not necessarily what is your diagnosis, but what would you do next? If you have a thoughtful approach for what you would do next, you will occasionally, and fortunately, come upon a diagnosis that was elusive and first pass. So you have to have a strategic way of assessing things. You're not going to do a pan scan on everybody, but saying, okay, some things that remain elusive. I can't understand why he has an apparent infiltrative pattern in his liver, and I can't yet explain why he has diarrhea. What will help me with that? Cross-sectional imaging of the abdomen. And in this case, it ended up being what I think pushed us towards a more clear diagnosis. And I suspect in this case, you guys did not get a paracentesis because I just don't think there was enough fluid or enough of a pocket to really get in there. Is that right, Maddie?
Yeah, that's exactly right. I actually went on the EMR right before this just to make sure I wasn't missing that, but they did not get a paracentesis.
Yeah.
But I loved how you kind of generally we do this, the reflection and cognitive autopsy at the end, but I think it's phenomenal to pause even in the middle of the case and think back on a reasoning process. And I also appreciate how you're thinking through which diagnostic test. Not everyone gets cross-sectional imaging, but under what circumstances is it indicated. So I will move forward with the basically the last aliquot. So I thought here I would give the official read of the overall impression of the CT scan. And the overall impression, as you all said, was a large mass, 6.4 by 8 centimeters in the transverse colon with extension into the gastrocolic ligament, consistent with colonic adenocarcinoma. And the innumerable lesions throughout the liver were suspicious for metastatic disease to the liver. And the moderate ascites was thought to be peritoneal carcinomatosis. And then the retroperitoneal and periportal malignant lymphadenopathy. So a diagnosis at this point was made of primary colon cancer with metastasis to the liver. So I wanted to ask, you at this point, how would you proceed in the management of this patient? We've gotten the CT scan, and kind of where would you go from here?
With a metastatic disease like this, I don't know if about oncology to know if this is curative. I mean, I've essentially, there's almost no metastatic diseases that are curative other than certain forms of germ cell tumors, and maybe nowadays some forms of melanoma and renal cell with immunotherapy. But by and large, once you get to metastatic disease, it's not a curable disease for these solid cancers. And so for a patient who's in this unfortunate situation, I would involve oncology, because there may be some agents that will provide some extension of life with good quality of life that hopefully can come along with it. I would involve palliative care, and I would involve general surgery, because even though a resection of this lesion is not going to be curative, a resection of this lesion will probably prevent, or hopefully can prevent, what would be the most catastrophic way to die from colon cancer, which is a total obstruction of the colon. It's absolutely miserable. So I would call them, not because I'd be asking them for curative intent. I would be calling them because I want them to seek, is a palliative resection an appropriate thing here? And if it's truly eroding, you're also trying to prevent sepsis, which would otherwise shorten this patient's life even further than it currently is anticipated to be. What am I missing, Eleni?
I think that's a very, very good plan. I would definitely get those consultants involved. Sometimes oncology does their weird gene testing, and they find fancy treatments, and they're always hopeful for the patients, but I will definitely involve those specialists. Now, I don't know if GI would have anything to add. I think oncology would be very appropriate.
And if I can just comment on one comment Gabriel made in the chat. So alkaline phosphatase can be in elevated intestinal conditions. That's absolutely right, because remember, again, alkaline phosphatase is elevated, or is localized, not just to the hepatobiliary system in the bone, but also again to the small bowel. So yeah, you can see it in actually many different foci. In this case, I'd be shocked if it weren't an isoenzyme from the liver. So what did you guys end up doing, Maddie?
Yeah, so I'll give you a little bit of the hospital course. So the patient underwent a colonoscopy with biopsy, and the colonoscopy showed a fungating, partially obstructing, so 2/3 of the luminal circumference, large mass in the transverse colon that was approximately 8 centimeters in length. And colorectal surgery was consulted, and they confirmed this was unfortunately unresectable stage 4 disease. So they recommended oncology to give their input for chemotherapy recs. So unfortunately, when oncology was consulted, they stated that the patient could not be offered conventional chemotherapy given the worsening hyperbilirubinemia. So when I went to check his EMR today, I was confirming how high it rose, and it went up to 16 and then to 18, 22, and the highest was actually 24 for the T-bili, which was the reason why ONC was saying that conventional chemotherapy would not have been helpful, I guess. And so biopsies were taken during the colonoscopy, and after a week or so, the biopsy came back, which showed poorly differentiated adenocarcinoma with neuroendocrine features, interestingly. So the immunohistochemical stains showed reactivity with CD56, synaptophysin, and AE1 and AE3. I actually haven't heard of that. So basically over the rest of the hospital course, unfortunately, the patient decompensated. He developed, as I mentioned, the worsening hyperbilirubinemia. Throughout the course, GI, IR, oncology, colorectal surgery was consulted. But basically, eventually, palliative care was consulted for just kind of comfort care, I guess, for the patient. And he eventually developed renal failure and was started on temperating measures in the setting of kind of the goals of care discussion with the family. So he unfortunately passed away, but he was on our team for a few weeks. So that was the hospital course summary.
And I'll just make a comment putting on my ethics hat. So 20% of my time I teach ethics, and this is one of the rare circumstances where the use of something like palliative sedation is sometimes raised. The old term for this is terminal sedation, but the preferred term is palliative sedation. And the idea here is essentially taking a patient whose suffering is unbearable and sedating them to unconsciousness and then allowing them to die. It is controversial, but legal. And the reason that a case like this is one where it is sometimes considered is when these patients fully obstruct. Because if he fully obstructed, no NG tube in the world is going to fix that. I think you could imagine that a total obstruction and the symptoms that could and would come with that would be tremendously unbearable. So it's unfortunate ending for this patient, but fortunate in that it sounds like your team with the expertise of palliative care was able to provide for him some degree of relief during a period that was otherwise going to be quite difficult.
Yeah, no, thank you for those comments. I had just very short warning points before I pass the mic to Shema, but I want to ask Eleni if you had any other thoughts you wanted to share.
That was a great discussion, fantastic case. I think like looking back again, what Dr. Breu said, kind of putting together the age risk factors, the presentation, and then like piecing together everything to come up with a diagnosis, and then ultimately getting the imaging that kind of fits with what the presentation was, the weight loss, the fatigue, the abdominal pain, change in bowel habits, kind of fit with this like textbook presentation of the apical core lesion. Unfortunate case, but really great discussion.
Definitely. One thing I really appreciated from the beginning, how you focused on localizing the lesion. I think even from the first aliquot, both of you mentioned that you were prioritizing a luminal process. So it was amazing that just even from the very beginning, you were able to narrow in on that. So that was phenomenal. So I appreciate your discussion. So I just had kind of just a few sentences of warning points when I just did some warning into this. I had never heard of colon cancer with neuroendocrine features. And I learned that they are very rare, but that approximately 10% of colorectal cancers, particularly poorly differentiated tumors, contain some foci of neuroendocrine differentiation. And generally, they're clinically very aggressive, and they carry a worse prognosis than adenocarcinoma of the colon without neuroendocrine features. And these tumors are heterogeneous, so they are composed of an exocrine component and a neuroendocrine component, which makes the treatment very difficult, of course, which is why it's generally very aggressive. So those were just some of the short learning points I had, and Shema, would love for you to take us away with the teaching points.
Oh, hello everyone. Very great case, Madalena, and great discussion. So giving you some quick teaching points. So we had constipation and diarrhea as the chief complaints, and this prioritizes a luminal problem, and especially if constipation is being followed by diarrhea, this is rather a large bowel problem. In terms of inflammatory bowel diseases, always look for extraintestinal manifestations like skin, eye, joint manifestation. Also, like if we think of ulcerative colitis, the association of PSC. And thinking of abdominal distension, is it any solid issue like organomegaly? Do we have fluid like ascites, like in this case, or is it any air? And thinking of this patient with jaundice and acute diabetes mellitus and weight loss and fatigue, we were thinking of a pancreatic adenocarcinoma or of a subacute inflammatory process. And also the lack of pruritus made the cholestatic process less likely. And thinking of a positive family history of cirrhosis, we were thinking, is there any hereditary issue like hemochromatosis, where we think of the involvement of the second and the third metacarpal joint? And also here, talking about ascites, as we know, a very common cause is portal hypertension, and the most common cause of portal hypertension is cirrhosis, but also consider non-cirrhotic lesions like schistosomiasis or Budd-Chiari syndrome. And also think of that there are also non-portal hypertension related problems leading to ascites like inflammatory process, infectious or nephrotic syndrome. And now collecting the clues for this case, we had anemia. Think of anemia of chronic disease in terms of inflammation. And also we had a normal albumin and normal INR. So we were rather not thinking of any cirrhosis. And the very high ALK phos made an infiltrative liver disease very likely. So if we have ALK phos above 600, think of any infiltration like a granulomatous disease, metastases, hemochromatosis, but also consider that ALK phos has other sources like the bone, the placenta, the small bowel, and also talking about the BUN in terms of cirrhosis. If we have a low BUN, this makes a severe liver disease more likely because the formation of urea is impaired in severe liver disease. And now having the final solution, constipation and diarrhea has been explained by a primary colonic lesion, which was already assumed in the luminal problem. And the very high ALK phos was being explained by the infiltration by metastases. So thank you very much.
Well,
Those
thank
are
you
great.
so much. Thank you
Thank
so
you.
much, everyone. Thank you, Shema. Thank you, Madalena. Thank you, Tony. Thank you, Eleni. Really, really appreciate it. Thank you, everyone. Hope everyone have a good week. Bye.
Thank